Bismillahirrahmanirrahim. Assalamualaikum. Good morning. Thank you, Madam Chairperson, for the kind introduction. And thank you for the organizers for inviting me to this Congress. Now, they say AI is for the future. Well, if that is true, that is looking to be a pretty smart future and a little bit scary. But let us demystify that, because the fact is that AI has caused a paradigm change, not only in the industrial sector, but its remarkable positive effect has rippled into the medicine and cancer pathology. Okay, now, however, that said, AI in social media is a topic of debate. Now, for example, these are the top 10 finalists Miss AI Award out of 1,500 automated applicants. I'm not bitter, but they are fake, non-existent female. Really, it's a toxic gendered norm bundled into unrealistic package. Now, let's go back into reality. AI in medicine. AI help us to develop new drugs and treatment, to diagnose diseases, and to, of course, develop personalized treatment plan. In fact, the AI-powered chatbots used in the healthcare industry provide patients with 24/7 support and assistance. Now, ladies and gentlemen, this is a very interesting slide for us pathologists, because we are already in the third revolution of pathology. The first revolution was 1953 to 2004, and John McCarthy was the first who coined the term artificial intelligence in 1956, followed 3 years later by Arthur Samuel, who coined machine learning. God, it's so long ago. And 1986, Rina Dacter coined the term deep learning, and 1988, convolutional neural network was invented by Young, and the whole slide scanner was actually introduced in the 1990s, and the first mutational assay for precision medicine was in 2004. Then we were all very excited because there is a second revolution, because next generation sequencing revolutionized all the molecular diagnostic technique all over the world. But it doesn't stop there. It was a short revolution. Now we are into the third revolution. Begins in 2017, about 7 years ago, where Philips received approval for digital pathology whole slide scanning imaging. And then a year later, FDA permits the first medical device using AI to detect diabetic retinopathy in the adults. And of course, FDA approved in 2021 the first AI-based software to detect prostate cancer. Now, in clinical pathology, really, AI, how can it help us? Now, for diagnostic application, for predictive and prognostic application, molecular and genomic profiling, research and education, last but not least, drug discovery and development. Now, for diagnostic application, the whole slide imaging help us to quantify biomarker like Ki-67, your immune biomarker, PD-L1, and it's so awesomely accurate. And then for the whole slide imaging can also identify micrometastasis in lymph node of breast and colon cancer, obviously improving the workflow efficiency. And the Gleason score for prostate cancer or breast cancer grading, reducing the inter-reader differences. That means to say there will be inter-reader reliability. Now, for predictive and prognostic application, AI helps us, for example, to detect the organization of tumor-infiltrating lymphocyte, and these are really very accurate prognostic model. For molecular and genomic profiling, AI helps us to predict the speckle type POZ protein, that is the SPOP mutation status in prostate cancer, and of course, model to detect microsatellite instability. Just a few weeks ago, Adam et al. From Sloan Kettering came out with a paper in Nature Medicine, AI-powered liquid biopsy deliver ultra-sensitive cancer detection, early lung cancer, melanoma, breast, colorectal, precancerous colorectal polyp. And of course, for the research, education, and clinic, AI allow us a dynamic interface for learning, annotation tool and ease of consult, and drug and discovery, of course, the prediction of response to anti-PD-1 antibody to nivolumab in late stage non-small cell lung cancer is one of the tremendous, achievement by AI. Now, when we talk about AI technology, I think a lot of our previous speakers had said about this. One of the advantages of being the last speaker, you get to summarize, right? Now, when we talk about AI, we talk about ML, machine learning. Now, machine learning identifies pattern in data. It could be reinforced, unsupervised, and supervised. Now, a subset of machine learning is deep learning, which employ neural network for intricate processing. And of course, you have transfer learning that addresses predictive modeling challenges like data labeling, leveraging pre-existing model for faster training. And transfer learning really has great potential for diagnostic and genetic research of gene expression analysis, mutation detection, genetic syndrome, genome-phenotype correlation. Now, ladies and gentlemen, a quick one. What is the difference between machine learning and deep learning? Now, machine learning is a subfield of AI. It is a computational system that attempts to identify relationship and pattern to make prediction on future data. It's pathologists like us that feed them what are the input data. For example, we make the nucleoli, how does it look like? The nuclear membrane, how irregular is the nuclear membrane, all right? Then this will then be fed into the algorithm base and classified accordingly, and will come up with a prognosis and prediction. On the other hand, deep learning is much more complex. It's a subfield of machine learning, where the artificial neural network automatically learn feature presentation in order to make prediction on future data. And how do they learn? From input layer, hidden layer, and output layer. And all these are automatically extracted by the convolutional neural network. Again, they will come out with prognostic and prediction, but the training style, if deep learning is supervised, semi-supervised, or unsupervised transfer, training style for machine learning are usually fully annotated images, optical images, right? Because of that, the training time for deep learning is obviously longer. The training time is less. The training time, the time for the machine to learn, yeah? Right? Then the algorithm complexity is obviously more complex with multiple layers in deep learning versus typically small model in machine learning. And of course, the data size in machine learning is on smaller data set versus requiring large data set on deep learning. Now, about 8 months ago, the University of Vienna Department of Neurosurgery announces that using laser-based imaging technique, they were able to actually have a diagnosis of the tumor during tumor surgery less than 2 minutes. The key word is less than 2 minutes. Now, this is the automated AI. You know that red, monitor there? That is the AI monitor. Now, with AI, the digital tissue section was created directly in the operating room, right? In the OT. And then it accessed and diagnosed within a few minutes versus frozen section. If you do frozen section, it has to be manually prepared. It has to go about 30 minutes. With this, it's less than 2 minutes because in neurosurgery, as in other surgeries, of course, the goal is a safe removal of tumor. Tumor boundary should be clear. Much more so in neurosurgery with a tight lapse of time interval. Now, across the Atlantic, the University of Michigan also releases this deep glioma AI-based diagnostic system that combine the deep neural network and the stimulated Raman histology that can achieve rapid molecular classification from fresh glioma sample. The keyword, fresh. There's no need for tissue processing or human interpretation in the OT, less than 2 minutes. So with this, they were able to have early cancer detection, a computer-aided diagnosis, automated tumor localization, and personalized treatment recommendation. Now let's look at this. How do they do this? Now, from the surgical sample from the patient tumor, it is then directly loaded into the pre-made disposable microscope slide with attached cover slip, and then they are loaded into the imaging system for rapid optical imaging. Now, they then have the simulated Raman histology, which are acquired sequentially as strip. Now, the image acquisition ranges from 30 seconds to 3 minutes. The strips are edge-clipped, field flattened, and registered to generate whole slide simulated Raman histology images, and then they are then used for the machine training and inference. Now, additionally, the slide can be colored using a custom virtual H&E scheme. Now, this is virtual, so the tissue is fresh. There's no manual staining of H&E. It's all in the OT. Now, for AI-based molecular diagnosis, what do? The whole slide image is split into non-overlapping pixel patches, and each patch undergo a feed-forward pass through this previously trained network to segment the patches into tumor region. And then they will then differentiate this into normal brain and non-diagnostic region. The tumor patches are then used by deep glioma at both training and inference to predict the molecular status of the patient tumor. So now, at the end of the day, they get this qualitative analysis of the SRH patch. Okay. The thing about AI is always a black box kind of thing, yes or no, 2 plus or minus, right? So the IDH mutation in glioma especially, you need to know about the IDH and the 1p19q co-deletion, because that is very important in their prognosis. Now, from these AI images, you can see that the blue is IDH wild type, IDH not mutated. The red is IDH mutated and 1p19q intact. There's no deletion in the short arm of chromosome 1 or the long arm of chromosome 19. But the green one, you see both, there is IDH mutation and deletion of short arm of chromosome 1 and the long arm of chromosome 19. Now, this is the AI images again. When we see that the IDH wild type or no mutation clustered at the apex, the IDH mutant tumor clustered at the base, and patient with IP19Q intact are closer here. The green one are the IDH mutation and 1p19q co-deletion. Why is it so important in glioma? Because they will affect the therapeutic response in lower grade glioma. Clinical data showed that IDH wild type glioma, that is IDH not mutated, are the most clinically aggressive, present with the worst prognosis, followed by IDH mutation non-co-deletion, and IDH mutation co-deletion is the best prognosis. The thing about genetic is not always a fixed rule. In lung cancer, if you are mutated, you get a better prognosis. In some cancer, if you are wild type, you are the worst prognosis, right? Now, this is also an amazing AI technology. It tells the patient, it tells the surgeon in the OT that the tumor margin is not clear. There's still tumor cell. So they can immediately go and remove more tumor cell, especially in a very tight lap surgery, like neurosurgery. Now, ladies and gentlemen, let's look visual tour into the breast cancer. Now, in breast cancer, AI has diagnostic, prognostic, predictive, right? For diagnostic, AI uses histological images and computational method to distinguish between different grade and detect invasive part, and they can localize metastatic spots. Now, these are the various papers from researchers all over the world. Input from myoepithelial cell, lymph node metastasis, and algorithm performance 90.9%. But the most exciting was last year, they used lymph node metastasis sensitivity of 100%. Now, for predictive, AI helps us to predict outcome of treatment in breast cancer patients. How? By quantification biomarker, estrogen receptor, progesterone receptor, HER2, and Ki67. And of course, some of these are also targeted therapy. With AI, we can also assess the neoadjuvant chemotherapy and risk categorization for adjuvant chemo and ER positive, HER2 negative breast cancer. Again, these are the papers from 2020 about AI-based predictive algorithm in breast cancer with various endpoints like HER2, estrogen receptor, neoadjuvant chemotherapy with accuracy ranging from 93.8 up to 86.7. Now, for prognostic, well, the AI has shown that the tumor-infiltrating lymphocyte, mitotic counting and grading level having one of the greatest achievements in AI for prognostic in breast cancer. Now, these are the papers for prognostic. We look at the mitotic figures. The Phyllodes tumor was very interesting. The correlation is up to 95%. And of course, others are breast cancer grading and other tumor-infiltrating lymphocyte assessment. Now, ladies and gentlemen, an example. Now, this is the automated lymph node metastasis using this AI software. They're not colored here, right? And then B showed how it is streaming the whole image into that database. Now, this is the analyzing the lymph node, and D showed the metastasis at the border, just at the wall of the lymph node. Now, again, it's beautiful. Now, look at that. A, B, and C. A, B is invasive cancer. Those are H&E, right? Or virtual H&E. It concordance very well with the AI red, that's a tumor cell. Now, this C and D is carcinoma in situ, which means the cancer has not invaded. The cancer cell has not gone into the stroma. It's underlined, very well defined by the basement membrane. And look at your AI, it beautifully defined that there's no tumor in the stroma. And this, another perfect image of AI, where in H&E, we're not able to see the calcification, but calcification are there in the AI. Now, in colorectal cancer, around about the same thing, pretty much they are able to show us the tumor. This is mucinous adenocarcinoma, is the H&E. This is the AI picture. Brown is the mucin, right? Now, AI pathology in colorectal cancer, A, D, G, and C are the H&E stain. Now, B, E, H, and K are the overlay of segmentation map. I mean, all those are in the processing of that AI pictures at the end of the day, and these are the final AI images. You look at it, the tumor, which is blue, is directly similar to that seen in the H&E. D, the tumor which is blue, it is equally similar to that in the H&E picture, and green is of course mucosa. And G, I find is totally amazing because you see the lymph follicle is not being invaded by the tumor cell. So the AI really cleared that out, and the tumor is out here. The same like that part of the H&E. And again, this is a mucinous CA. The blue color is the tumor cell. Now, for AI for tissue biopsy, probability of concordance is 99.1%, and it is so fast, 2 minutes. Now, what are the overview of possible opportunities and challenges associated with implementation of artificial intelligence and digital pathology? We also use the word digital pathology like in those slides that I showed earlier. So now there is inter-pathology objectivity greatly reduced. With AI, we are able to identify subvisual structural characteristics, more efficient completion of laborious tasks like completing mitotic count, obviously quicker patient turnaround time. Spatial algorithm can analyze the geographical context of data. And I like this part, readout can be easily accessed remotely by pathologists, right? And capable of analyzing and predicting instability and mutation within histopathological images, and can infer information on patient immune response. But of course, in any system, there will always be challenges. What is the challenges of digital pathology, so to speak? Significant amount of digital histopathological sample required for training and testing. We need lots of data. Required extensive clinical data accompanying image data. And of course, at this point of time, there's lack of multi-center, prospective and randomized trial evaluating performance. Of course, it's super expensive. Computational expenses, as in the requirement of GPU, not to say the long-term cost of data storage. Of course, in the West, it's absent of reimbursement model in our setup. I do not know how we're going to address that. Now, in AI or in digital pathology, binary manner of classification is a black box like a thing, yes or no, malignant or benign, recurrent or non-recurrent. Whereas we know in the real world, it is much more complex, right? So we are not going to lose our job. So lack of guidelines surrounding the annotation, image and lab requirement to mimic natural variation. Now, ladies and gentlemen, how about AI in genomics? This is much more complex, because even in your NGS level, there are loads of data, right? Just now when you look at neurosurgery, they're looking at 3. IDH, 1 part, 1P, and 19Q co-deletion. So that's pretty simple. But when we talk about genomic, lots of data, right? So the deep learning in genomics are more diverse model, more involved in advanced tasks. In histopathology, the basic model architecture were adapted from computer vision, from the optical images, but not so from genomic. So deep learning in genomic did not find a direct analog in computer science, leading to broader experimentation with various model types. Therefore, the approaches toward mutation prediction in deep learning differ between histopathology and genomic. It's still evolving the technique. At least in liquid biopsy, it has been proven to be a doable thing. But for tissue, I think we are looking at 2 or 3 at the moment. Okay. Yeah. Okay, because in genomic, we can analyze genomic data by classical bioinformatics, the algorithm to perform tasks, i.e. sequence alignment, variant calling, or differential expression analysis. But these algorithms are highly engineered and focused on finding patterns which are predefined by human experts, as opposed to utility of AI for clinical genomics, where we expand the toolkit by deeper data analysis. So patterns that are unknown or undetectable to humans, like the way a protein folds into final shape, or the mutagenic process in our DNA will be missed by the human eye. So revealing the novel paradigm of AI will lead to innovation in clinical genomics not possible for standard bioinformatic approaches. Now, these are all the aspects of AI with accelerated sequencing, reduced error, improved variant identification, personalized medicine, population study, large-scale structural variation analysis, data integration, scalability, ethical consideration, regulatory compliance. And in cancer, especially AI, we can analyze genomic data by machine learning to learn the pattern. We can identify at-risk population. We can classify genetic variant, and we can predict ancestry of patients, which is important, especially in disease that, associated with particular population. Right, okay, what next? What are the future of AI? AI will face in the next years larger and fairer data set, swarm learning. What is swarm learning? Swarm learning is swarm intelligence, collective behavior of decentralized or self-organized system, a swarm of bees, a school of fish. Why people flock into a certain thing? What are the criteria? They say that will be good in industry, but we're looking also at leukemia. It's one of our research projects. Data curation standard, explainable AI, self-explanatory, because it allows us to understand how the AI works. And because of that, we can comprehend and we will trust the result and output created by machine learning. Digital infrastructure, generative AI, model updates. Okay, the challenges and opportunities for AI in cancer. AI gives an unprecedented potential to enhance patient outcome, faster and more accurate diagnosis. But if the data used to train AI model are not diverse and not representative, there will be medical bias. So it's very important. So there is ethical dilemma and legal complexity. There is, of course, issue of transparency, accountability, and we need to ensure patient privacy, data security. We need for broadly accepted and adopted standard for AI and machine learning to mitigate bias. We need more randomized clinical trial to validate application. At the end of the day, we need a multifaceted approach that include not only legal framework and regulation, transparent and explainable AI, ethical guidelines, standard regular audit, assessment, even incentive for ethical practices and international collaboration. I was hoping that I would be able to give this slide, so that's why I'm rushing through. So do we have this AI at home? Yes, we do, right? We have this. And I'm not going to go into this because at the moment we are doing cytology diagnosis, because Professor Cheong has given an eloquent presentation on the perhaps staining of AI, and this is diagnostic. We are using it for diagnostic, and right now we are validating this for H&E, and our partner institution is using the same AI in 2 minutes of neurosurgery in Canada, the same scanner. But let me tell you, the limiting factor is not the scanner, it's the AI BIOS software. It's 1 million and above. Okay, and again, I would like to say that we are pleased to say that we are part of the research for the UPSI in AI in terms of feature selection. In that, I thank you all for your kind attention.
Thank you very much, Professor Roziana, and to all 4 of our speakers today for the wonderful talks. So I have to apologize to the audience because we are running very late. I unfortunately will need to cut the Q&A session entirely, but our speakers will be around and I will allow you to catch them during the session, and maybe I see very sad faces, but yeah, maybe you can ask them and think about which session you might want to skip, because we have a session at 11 o'clock at this venue and we need to set up. So, and I also need time to present the token of appreciation to our speakers. So may I invite the 4 speakers, Dr. Anna, Prof. Cheong, Professor Chong, and also Professor Roziana to accept the humble token of appreciation from the organizers.
Okay, 1, 2.